one that got my attention. This is on our Peter Attia's Reddit. And this person is trying to get an ezetimibe prescription from their primary care physician or GP. I look at their numbers. The numbers are actually pretty good. LDL cholesterol is at 96. Their apolipoprotein is at 79. Do not have diabetes. They're not even close to pre-diabetic. They got a coronary calcium score that was 0, which means there are no calcifications. And I'll talk about that in a second. There's no calcifications in their arteries. So, but they want to lower their LDL and ApoB down a little bit further. They want to start an ezetimibe with that, and their PCP is not going to do that for them. So they're asking, should I get another one? I'm going to talk about the ezetimibe side of things because I think this is a really interesting medication that doesn't get a lot of press, but is quite helpful. Really quickly on the calcifications. When you do have one of these plaques in your artery wall and your arteries getting narrowed, one of two things can happen. The plaque can become unstable and eventually lead to a blood clot, which is really what you don't want and often is what happens when someone has a heart attack. Or the plaque can heal and you get some calcium deposition on there. And over time, your body essentially cements it in like the biologic equivalent of concrete, which is calcium, and just layers it over and over there. Obviously, you'd prefer this latter process. So when you get one of these coronary calcium scores, you're looking to see if that process has occurred. And you might say, well, if that's the plaque healing, why do I care? It's an indication that the earlier stages of the process have been occurring. So you are at greater risk, and it's possible that you do have some of this unstable plaque there. So really that calcium test, if it's positive, it's sort of a wake-up call, and then to say, hey, let's go investigate this further. In that way, it is a great screening test. Now, ezetimibe. Ezetimibe is a medication that was approved by the FDA in the US in 2002. So we've had over 20 years of this drug being on the market. And it works by blocking the absorption of cholesterol from your small intestine. What happens, in effect, your liver cells, they suck up cholesterol from your diet and they use it internally. If they are not able to absorb it through your gut, and they're going to pull it out of your bloodstream, thereby lowering your cholesterol levels. It has a extremely good safety profile. The only real side effects are nausea, diarrhea, and fatigue, and that happens in less than 5% of cases in either of these. And they've actually found in the studies they've done on it that it occurs very rarely above placebo. So when they've done these studies, the same amount of people who didn't get the drug had fatigue, nausea, diarrhea. So you could argue that they may not have any side effects at all. One thing I want you to keep in mind is if a drug has been around for 20 plus years and a lot of people are taking it, I was reading that as of 2023, 9 million people are on this medication. If there were some rip-roaring side effect, we probably would have heard about it by now, and it probably would have been studied. Now, of course, it's possible that in 40 years, if somebody's been on it for 40 years, there's a side effect that we never knew about that shows up, but it's becoming less and less likely as time goes on. Coming back to this patient, you'll say, well, their ApoB is pretty low already. They don't have any metabolic disease. They may not have a lot of inflammation, as we were thinking about the different things that cause heart disease, cause that plaque to form. Maybe they don't even have high blood pressure. Do they really need to lower their cholesterol? I would say that's a fair question. They may not, especially if they got that coronary CT angiogram and they saw the inside of their blood vessels and it's totally clean. They don't have calcifications, but they could go a step further and say, we really see what's going on in here. But is it worth it to lower it? And it all comes down to a principle that I think is really important in medicine. What matters is the risk versus the reward of treating it. And what I'm trying to pose to you here is that ezetimibe has very little risk. I mean, we haven't seen really anything in terms of long-term side effects, and the chance of a short-term side effect is still very low, and they're all really minor. And then it's kind of up to you. Do you want to take that risk that there is a side effect that pops up in 30 years or not? I think it's fair to say, no, it's not worth it, especially for someone like this who has great cholesterol markers. Now, if your arteries are crazy clogged and you're at very high risk of having a heart attack, then take the ezetimibe. So I want to express that this is the way to balance this, all probabilities. Unfortunately, we don't have a ton of certainty in anything in life, certainly not in medicine. The other thing I want to show you is ezetimibe is insanely cheap. I actually take it myself to lower my risk. It's $3 a month with insurance and about $15 a month without insurance, right? So less than a takeout meal these days. So, last thing I want to express to you all talking about is this doctor here sort of shutting this patient down and saying, no, we're not going to get this for you. It's not worth it. I don't think this is great medicine because, again, it comes down to the risk reward. And I don't really see what the risk is of taking ezetimibe in this patient. Obviously, if they try it and have bad side effects, that's not worthwhile. But that doesn't seem to be the case in this situation.